Hey, hello everybody. It's Sherry from the CGH Health Foundation and welcome to our weekly Facebook Live program. I know you're used to seeing Dr. Bird here, but he's taking the week off. And this is one of our Growing Healthier programs, which we focus on a specific health issue or condition. And this month's topic is osteoporosis. And in a minute, we'll have Dr. Marcia Jones from our family medicine practice at the Lynn Boulevard Clinic. And she will actually be interviewing and talking to Dr. Debra Bowman from our obstetrics and gynecology program about osteoporosis. It is National Osteoporosis Awareness Month. And before we go there, I just want to talk to you about the CGH Health Foundation. The CGH Health Foundation's mission is pursuing healthier lives for people of the Sauk Valley. And we just kicked off our campaign year with our silent auction, just wrapped up the other day. And we wanted to make sure we said thank you to everybody who either donated something to the auction or who purchased something from the auction. We raised over $13,000. So it was our best auction ever. And it's thanks to people like you that we can continue to provide the services that we do. We have over 20 programs and services that keep all of your donations right here in the Sauk Valley and help people right here in the Sauk Valley. And for the next year, our special emphasis is going to be continuing in mental health and expanding our mental health services. And that will mean more time available for our patients to have access to them, and with a special emphasis on new mothers and expectant mothers, because that has been a group of people who's been very highly affected here. So that's what the Health Foundation is up to. Next month's program will be about men's health, and our presenter is going to be Kevin Rogers from the urology department. And that program is going to be on June 3rd, again, a Facebook Live program at noon. So that's what's going on here. And I will go ahead and turn it over to Dr. Jones.
Thank you so much, Terry. Thank you, everyone, for joining us today. I'm your guest host for today's Facebook Live program. We'll have a conversation today with Dr. Debra Bowman. At the end of the conversation, we will have a summary update of how we're doing here at CGH with our COVID vaccine process. Dr. Bowman has been at CGH since 2019. She comes with a distinguished career. She has a wealth of knowledge and experience, and she's going to share some of that with us today. Let's bring Dr. Bowman in.
Good afternoon. Thank you for inviting me.
Welcome. Thank you for joining us today. So we like to start off a little bit by getting to know who our guests are today. So let's start by sharing your story with us. So what made you decide to go into medicine and ultimately choosing OB-GYN?
Well, as I was growing up, I had several relationships with different family doctors, and I became interested in the medical field. When I was in college, I did some volunteer work. Some was at a hospital, I worked at a nursing home, I also worked at a home for teens. So through all of college, I've kind of really enjoyed working with people, and I wanted to be able to help them. And I thought that medicine was a good way of doing that. So I went to medical school.
Wow, wonderful. What made you choose OB-GYN of all the specialties?
Well, I went to University of Illinois in Rockford, and there they had us work through family practice clinics, and mine was in Belvedere. And we'd have different families that we were given the responsibility of taking care of them. And I love the continuity of care, starting from babies through teenagers, adults, going to, women going through menopause, even nursing home patients we had too. So that was very important to me. And I wanted a field where I would be able to know the patient and be able to see them year to year. I also liked surgery. So having a little bit of surgery, a little bit of office, and OB seemed to kind of provide that with the obstetrics and the gynecology. So I went into OB-GYN.
Wonderful. Well, we're happy to have you here. Out of curiosity, how many babies have you delivered thus far?
Well, I've been doing this for 33 years. So I kept track during residency and also during probably the first couple of years of practice. But after that, then I have not kept track, but I think that probably size of a small town, I've probably delivered. So,
wow, a lot of happy parents and happy babies out there. Yeah. Let's switch gear a little bit and talk about our topic for today, bone health and osteoporosis. Why are we talking about that? Why is it an important topic to discuss?
Well, bones are very important structurally for our bodies, and they are quite a dynamic organ. So they're constantly being reabsorbed and being remade. And so this formation is important, and through life, it goes through several changes. So as you're growing up, your peak bone mass is going to be at 19 to 20 years old, and you keep that for about the next 10 years. But after that, it starts decreasing some. So women will notice when they breastfeed, when they are pregnant, and then as they go through menopause, these are lower estrogen times, and the bone loss is greater. The turnover is greater, so more bone is being lost than being made. So eventually it kind of catches up with you as you get to menopause, and you can develop some fragility in the bones because they are not as strong. And then that leads to fractures. So we are trying to catch this before it happens and see what we can do to prevent it. And then once it has happened, how to treat it and take care of it.
Wonderful. Very, very important. What are some of the risk factors that are out there for developing osteoporosis?
Some that they'll list, one, of course, is advanced age. For women, we look at women who are 65 and over. Men, I think they use 70. Also, if you've had low body weight, so under 127 pounds, puts you at higher risk. Smoking increase your risk. Alcohol, more than 2 drinks a day. Also, caffeine can do it, more than 2 servings a day. Other things can be medication history, like steroids and other things. Other medical conditions like diabetes or thyroid, rheumatoid can also do it. So once you've had a fracture, a fragility fracture, too, that also increases your risk. And if you have a parent who's even had a hip fracture, that can be a risk factor too.
Certainly a lot of risk factors out there to keep track of. You mentioned medications and chronic conditions. Can you elaborate on that a little bit more? What are some of those medications that are there?
Sure. So the bigger ones that we would hear a lot about are like steroids. And with that, you'd have to be on 5 milligrams for 3 months or longer. So other ones would be blood thinners like heparin, thyroid medication sometimes, seizure medications are even listed, a lot of chemotherapy or immunosuppressant medications, proton pump inhibitors, which people use for reflux. Those can even cause it. Even some of the antidepressants may cause it. So we have lots of different medications out there, and the doctors who are prescribing should be able to go over some of that risk. For OBs too, we use a birth control that's a shot that you get every 12 weeks. It's called Depo-Provera or medroxyprogesterone. That also can increase your bone loss if you use it for longer than 5 years. But the nice thing with that one is when you stop the medication, most of that bone loss comes back.
Okay, good. And certainly we want to remind people if they're on those medications, because they're concerned, don't stop. Have a conversation with your provider before deciding what next to do. Wonderful. Okay. Now, if you have osteoporosis, how is this detected? How would you know that you have osteoporosis?
Well, there are things that as you go to your family doctor or gynecologist that they would be asking you from your history. There are different things that we use from your history to calculate what we call a FRAX score. So that's fracture risk assessment tool. They use things like your age, your sex, your race, your body mass index. If you've had a previous fracture, especially a fragility fracture, if you are currently smoking, using steroids, if you've had alcohol more than 3 drinks a day, and other causes like rheumatoid arthritis and those medical conditions that make you more susceptible. Those can be determined from your history. On your physical exam, they'll be taking your height, your weight, and looking for any compression fractures in your spine would lead to your height losing from what you had measured before. And also your spine and the structure of that can be told a little bit on exam. So besides using that, then we use an x-ray. So if you meet the criteria, then doing what we call a DEXA. So dual energy x-ray absorption, and it's done in radiology. And based on that, they look at your 10-year probability for a hip fracture or osteoporotic fracture. And you can tell if that, compare it to youth cohorts, younger patients, so it's determined by a T-score. So I think we may have a slide that shows what a normal score would be from the DEXA. And if it's -1 or higher, then that's a normal bone density. If it was between -1 and 2.4, that would be more consistent with osteopenia or early bone loss. And then Osteoporosis is when it is less than the negative 2.5. So that means your fracture risk is going to be higher. We no longer use any heel scans. I think they used to do that with ultrasound or CT scans, but we've kind of stopped doing some of that. So it's mainly more based on your exam and then determining if you need a DEXA scan.
Okay, wonderful. And regarding the heel scan, some of those screening that patients do independently on their own, use some of those. And if those are used, then we defer to, as Dr. Bowman mentioned, the DEXA scan that's preferred. Now, since we know that there is screening, what are the latest guidelines as to when to screen and how to proceed with that?
So there's many different societies and tell us many different ways of doing who needs it when. The majority of them do use that women over 65 and over. Men, I think it's age 70 from what I could tell. I don't know, Marcia, you may be able to tell me better since you have male patients, but from what I could tell, it looked like 70 years old. If
that's the general guidelines for 70 for men.
Okay. And then postmenopausal women who are less than 65 but have risk factors from either their medications, their medical diagnoses, or those risk factors for the FACOG score, those would be other women who would be could have a DEXA scan prior to the age of 65. And I believe also for men who have some of those risk factors, they can have it too. And then, of course, if you've had a fragility fracture, so these are fractures in either the spine or the hip that are from a low trauma. Also, you can get them in the wrist too. So those are people who are automatically diagnosed with osteoporosis and would need a DEXA scan.
Okay.
Just other recommendations is once you've had a DEXA scan, is how frequently do you get them? So say you're 65, postmenopausal female, and you have a normal bone scan, you can recommendations are to do it again in 10 to 15 years. If you had some osteopenia or early bone loss, it looks like about every 3 to 5 years, unless you develop any new risk factors. And if you are diagnosed with osteoporosis, it's usually every 2 years or sooner, depending on medications that you're on or what your prescribing physician feels that they need to do. But it's usually at least every 2 years. The FACOG score you can do in the office with your doctor, or they do it when they do a DEXA, but they recommend doing that about every 5 years.
Okay, thank you. Now, are there treatments available for osteoporosis, and how would a woman decide what's the best treatment for them?
So there are many different kind of treatments. Of course, always calcium and vitamin D should be at the top of your list. So we'll talk a little bit more about that later. But besides those, I'm getting on to prescription medications. For a woman who is going through menopause or has just recently gone through it, hormone replacement therapy is at the top of the list. They will be losing their most bone loss between the year before their periods stop and the first 3 to 4 years of menopause. So during that time, they can lose 6 to 7% of their bone mass. So actually putting them on hormone replacement therapy will reduce their risk for both a spine and hip fracture by 33 to 36%. So hormone replacement therapy is still something that's highly recommended if you're just going through menopause. This is the time when the highest turnover of the bone is, and so that's why the bone loss is more. Of course, there's contraindications to using hormone replacement therapy, and not everyone wants to use hormones. So because they can risk for breast cancer, heart disease, strokes, blood clots could be increased. But from the WHI study that was done like 20 plus years ago, they did come up with that the hormone replacement therapy, either estrogen alone or estrogen and progesterone, those can decrease your osteoporosis risk, and they also decrease colon cancer. So those are the two good benefits about being on the hormones. So that would be a consideration. Another one would be that of using, most people use first-line medications that are called biphosphonates, and there's many different kinds. I'm not sure what kind you like, Marcia, that you use the most in your office. Do you use allodotrate? Is that the one?
Eledronate, yeah. First line is usually eledronate, and of course, always offering the orals before the injectables.
And they're usually a little cheaper. They're more commonly used, don't have as much side effects. Some of the rare ones, but you hear a lot about them. One is the osteonecrosis of the jaw, but the risk of that happening is 0.05%, so really very low. Also, atypical femur fractures, if you stay on the medication, it says longer than 7 years, like if you have rheumatoid or other kind of medical conditions, or Asian, they said too. So a lot of people will use that probably for only 5 years. Is that the standard of care for that one?
Yes, and then you can reassess based on their risk factors, based on their last DEXA scan and FRAX score, whether or not it's worth continuing again, or if we could give them a break or a holiday from the medication.
And then from there too, sometimes they go to Prolia, which is an injection that you could do every 6 months, and that one you can use for up to 10 years. So that's another one you can go to also. It causes some rashes and cellulitis. It does have the warning too, also for the osteonecrosis of the jaw and the atypical femur fractures, but the same low risk for those. So that's another one that's available to use. So both of those help to build up the bone, and that it prevents the bone loss from occurring. So next you have other medications like relaxafen. Some women will use this when they have a breast cancer or family history of breast cancer, as it can lower their risk. The unfortunate thing, because of being an anti-estrogen, it does give them more postmenopausal symptoms. So then they have that to deal with. Also, it can decrease the risk for vertebral fractures mainly, whereas the other ones can do both. If you've had a stroke in the past, you would want to maybe avoid that too. Other medications, you get into ones that are daily injections. They can help to promote your bone growth so that you can decrease the turnover because you're giving better bones there. So those are daily shots. And then there's some medications that help to decrease the bone loss, but also to help promote bone growth. So that turnover leads to more of a net gain. And those are monoclonal antibodies, so a little bit more unusual, and those are monthly injections. It can do for 12 months, but they do have a little cardiovascular risk too with those. So I don't know, is that something that you would use in your office, or is that more like by a rheumatologist that you use those?
That's more by the rheumatologist. We would go over the different availabilities and then refer them on if they're not a candidate for the ones we talked about, like the Alendronate and the Prolia and those others.
So, for example, if we have a 51-year-old female who's now in menopause for about 6 months, and she slips in the shower and fractures her wrist. So that's considered a fragility fracture or low trauma. So if somebody like that would come into your office, then one consideration that you could do is probably consider using hormone replacement therapy, as long as they don't have any contraindications to it. And you can make sure they have a good mammogram. You can do a lipid panel. You can consider putting them on a low-dose baby aspirin if you want at the same time when you do that. But using the hormone replacement therapy for that first 5 years will help to really reduce their bone loss and the bone turnover. If you use that for the 5 years, then at that point you could consider changing her to a biphosphonate and doing something like the weekly pills, Fosamax, and doing that. And you could do that for up to the, would we say 5 years?
5 years.
Kind of reevaluation or drug holiday. So that would get her to probably 10 years down the road. So now she's in her early 60s. And then you could consider doing the Prolia injections every 6 months. And you could even do that for 10 years. So that would get her into her early 70s. So from there, her risk for the fracture of the hips, you've really reduced her risk by 20 years. So they say women who don't use any kind of therapy, medications, their risk for a fracture by the age of 80 is 15%. And I think for men, it's about 5%. So if you can extend her bone growth and give her healthy bones for that next 20, 25 years, you've really made a big difference with that. Once women have had a fracture, then they do have other risks too. So once you've had a hip fracture or wrist fracture, your risk of another fracture in the year can be as high as 19%. If women have a hip fracture, they decrease their lose their mobility, and only 56% of women will be able to walk independently at a year. So then you're more dependent on your family or a nursing home. They even said that 3 to 6% of females can have complications from the hip fracture and not even make it out of the hospital. So you really want to try to prevent that hip fracture. So say that lady was 60 years old and slipped in the shower and got her wrist fracture. So now she's past the time that you would want to use hormones. And I would just go directly to the Phosphonates or and doing that, or you could do that for the 5 years, get her into her mid to late 60s, do the Prolia, that'll get her into her mid to 70s, and then stopping it. And again, you've still helped her bone loss and improved that time. So there's many different options, and sometimes people will want to do them, and other times they kind of hold off, and you would repeat your scan based on your risk.
Okay, good. We've got a question from the viewer here that says, so if you're age 70, hormone therapy is no longer beneficial to start, even if you have several risk factors.
Correct. You need to start it within the first 3 to 5 years of going through menopause. So if you hadn't been on it and you're 70, it would not be good to start it.
Exactly. And as you mentioned, we would start with the other medications, the Boniva, Prolia, and those others.
Right.
Okay, wonderful. So you also mentioned a little bit earlier that we'll do a deep dive into calcium and vitamin D. What is the latest research on the effectiveness of these supplements on osteoporosis?
So recommendations are to use calcium 1,200 milligrams a day. They recommend that you don't do more than 500 milligrams in the supplement. There were a few studies that talked about if you had over the 500 milligrams that you could have some increase in cardiovascular disease, such as the calcium being deposited in the arteries. So that's still being debated about how much from supplement versus diet. But of course, diet would probably always be a little bit better. It's always best if you can get it. A lot of times we recommend to women, 4 servings a day, and a serving is 300 milligrams. So you could do 8 ounces of milk, 4 ounces of cottage cheese, an ounce of cheese, 8-ounce yogurt. So those would each be considered a serving. Now, there are a lot of calcium in other sources besides animal protein, though. So dark green vegetables, some nuts, breads and cereals have been fortified with it, soy products, fruit juices. So doing calcium from other sources rather than always animal protein is better. They do show in some countries that have a low animal protein intake that they have a lower hip fracture, whereas Norway, Sweden, and the US have a higher animal protein, and we have some of the highest hip fracture risks. So trying to get your calcium in through other forms of your diet are beneficial. The vitamin D, the recommendations that I could find, we're starting at about 800 international units. You can do a level of your vitamin D and see where you're at. The current recommendation is to have that in the normal range between 30 to 100 is what most people use. Some people use over 20, but I think the majority of people at least wanted over 30. So if you were already on 800 international units of vitamin D, you have a low vitamin D, you may need to take more. So either over the counter or as prescription. Vitamin D helps your calcium get absorbed, so that's why it's important along with that. Sunlight you can do too and get your vitamin D in, but then we worry about skin cancer. So you have that problem. But and as you're over 70 and it sounds like you don't get the same absorption from the sun, it sounds like the efficient absorption of the vitamin D isn't as good as when you're younger. So that may hinder it a little bit more too as you get older. So there is over-the-counter vitamin D2, which is called ergocalciferol. And then there's vitamin D3 that is co-calciferol. And the preference is the vitamin D3 if you can do that. I think with the calcium, there was calcium carbonate and calcium citrate are the two supplements that are out there. Sometimes they're, one you have to take fasting, the other one can bother your GI tract a little bit more, but those are the two more commonly known ones. But I think calcium citrate is probably the preferred one for that.
Definitely. So we've talked a lot about, what osteoporosis is and how it's treated with medication and supplements. Are there other things that women can do besides this on their own to prevent and treat the osteoporosis?
Well, I think the first thing is don't start smoking, because then you don't have to stop smoking. Other thing is to pay attention to your caffeine intake and try to keep it under 1 to 2 servings a day. Alcohol, they recommend less than 2 drinks a day for women. I'm not sure if it's different for men. Of course, weight-bearing exercise or resistance kind of training, any of that will help to keep the calcium in your bones. So even being good at exercising when you're 30 years old and watching your diet at that point in time will help give you better bone health down the road. So they do recommend if you're for the exercises to do at least 30 minutes and 3 days a week. Another thing to prevent fractures as you get older, exercise definitely helps your balance. So that would be very helpful in doing that, even if it's yoga or some other exercises that you can find online. Also using night lights so that you have a light available so that when you get up in the middle of the night or have to go to the bathroom that you're not falling. Don't use throw rugs. Those are a high trip risk. And getting rid of that. Using the handrail when you're climbing the stairs, and maybe even need a handrail in the shower or by the toilet in order to help you too. Of course, the other time is when we have icy weather and the risk for fall outside. So using something like yak tracks and making sure you have good shoes, and that would be best for you too, to prevent the fall from the beginning too. So those are some other things. And then watching your calcium and your vitamin D would always be good things throughout life too.
Very good. And of course, starting when you're young, as you mentioned, with the exercises, is always a good asset.
Very good.
Wonderful. So let's switch gear a little bit and talk a little bit. You did talk about hormones and how that affect osteoporosis. What are the recommendations about women and menopause, perimenopause, and hormones?
Well, 20 years ago when the WHI study came out, everybody went off their hormones. So then they all had their menopause symptoms again. So we now, recommendation is, there are reasons to use hormone replacement therapy. There's many forms of it. And the goal is to use the smallest amount to treat your symptoms and for the shortest amount of time. Usually, even when you wean off of hormones, eventually after 3 to 5 years, you may still get the hot flashes and the night sweats, and those may still come back for a little bit of time too. But it comes as a pill. There's also patches. There's a vaginal ring, vaginal suppositories, vaginal cream. So there's other ways of doing it, and the oral ones can go through the liver. So if you use the patches or one of the other forms, it can bypass the liver and maybe less likely to affect your cholesterol.
Certainly, and less likely to interact with other medications that are processed through the liver. What is the best way to taper off hormones?
What is the best way for what?
To taper off these hormones.
Well, you decrease the doses. So say you're on a 1 milligram dose, you'd want to cut it down to a half of that and do that every day for several weeks or several months. And once you're feeling like you're not having too much as far as the symptoms, then cut it down again. There's 0.25 and you can kind of wean down. And once you get to that lowest dose, then some people will do Monday, Wednesday, Friday for a couple months and then gradually be able to stop too.
Okay, good options. Okay. What are the latest recommendations about screening for Pap smears and pelvic exams?
Well, pelvic exams could need to be done even on teenagers and up to the age of 21, but may not need Pap smears. But there's other like sexually transmitted infection testing and birth control to be discussed, and even the HPV vaccine to be done. So, but at the age of 21 is usually when we start doing the Pap smears with the pelvic exams. And checking for the normal cytology every few years. After 30, you can do what's called a DNA Pap smear, and it looks for the high-risk wart virus along with the cytology. So that Pap smear can be good for 3 to 5 years even in those women. And we would need a pelvic exam every year because we still like to be able to feel the uterus, the ovaries, do the breast exam, counsel, talk about diet, smoking, exercise, anything for prevention too at the same time. So
good. All right. And our final question is, as far as menopause is concerned, is there anything that can be done besides hormone to help women with menopause?
Sure. Of course, women's main problem with menopause, their main complaint is the hot flushes, the night sweats that we usually hear, and trouble sleeping. So there are some soy products that a lot of women have tried before they come in to see us, and something like that is reasonable. And if that's not working so well, then they'll be coming and asking for other things. We do use some antidepressants in lower doses. Studies were done in women who use like Prozac in a higher dose, and it helped their anxiety, depression, but also took away their menopause symptoms like hot flushes and night sweats. So starting them on a low dose of that sometimes will help take away those symptoms too. Women who've had breast cancer or blood clots can't use hormones. So if they're getting pretty desperate, the other next medication we go to is gabapentin. And it's used for many different kind of things, chronic pain and I don't know what else, but neurologic neuropathies, I think too.
Yeah.
So, we do use that, and that takes care of the night sweats and the hot flashes too for a lot of women. And they can stay on that indefinitely, very few long-term side effects that I've heard of, but they can also wean off of that eventually. The latest conference I went to last month, they talked about even oxybutynin may be something that helps women with menopause symptoms. A lot of times we use it more for incontinence and overactive bladder, which can get worse with menopause, but it seems like that has helped their menopause symptoms too. So, of course, there's contraindications to using any of these medications. So you'd have to look through that and discuss it with your doctor before you can get prescribed that.
Wonderful. So certainly good to know there are a lot of options out there besides hormones for women. Wonderful.
The other thing I forgot, though, with the Pap smears, when we talked about the 30 years old and starting their DNA Pap smears, we don't usually recommend doing Pap smears after 65. So you may still need pelvic exams and feeling the uterus and the ovaries if those are present, looking for prolapse, other kind of conditions too, but wouldn't necessarily need Pap smears after 65. And if women have had a hysterectomy for benign reasons and the cervix has been removed, they also would not necessarily need a Pap smear, but they would need a pelvic exam.
Good point. And a lot of women are happy to hear that there is a point that they don't need to necessarily have a PAP, though they still need to have an exam and a discussion with their doctor about what else needs to happen. Good. Well, Dr. Bowman, thank you for all this wonderful information today. I learned a lot myself. The viewers, I'm sure, learned a lot. And, we look forward to having you back again for another series.
Well, thank you for inviting me. Thank you.
Thanks. Good afternoon. And I want to remind the audience, for additional information on osteoporosis, you can go to familydoctor.org and type in osteoporosis. It's a trusted website by the American Academy of Family Physician, and there's more information there as was discussed today. We'll switch gear a little bit and talk about how we're doing here at CGH with regards to our COVID-19 infection and vaccine. And Matt has a data report that we can put up on screen to be viewed. And what we have is a comparison between April 29th and May 5th. Of course, we like to keep track of what we're doing as far as positivity rate here in Whiteside County. So as you can see, it's 3.8% for the most recent one compared to 4.1%. So the direction is certainly where we want to go, but obviously there's always room for improvement. So we'd like to encourage everyone to continue to follow the guidelines out there. Wear your mask, wash your hands, social distancing, and of course, we cannot leave without talking about vaccinating, okay? As far as how we're doing with regards to vaccinating here at CGH, the total of patients that we've had with the first dose thus far is 5,773. We've had 4,340 who've got the first dose so far. And this week, we plan to administer 646 doses this week. Our next clinic on the 14th of May, we plan to administer the Moderna vaccine, and there will be 570 doses at that time. I'd like to also encourage everyone out there to have a discussion with their healthcare provider, doctor, nurse practitioner's PA, about not only the COVID-19 virus itself, but the vaccine. If there are questions that you have, concerns about the vaccine, please have those questions answered as soon as possible. The vaccines are safe, they're effective. We do know that in order to conquer this pandemic, we all have to do our part, but also means we have to vaccinate for ourselves, for our family, and for our community. There are always concerns about side effects of everything, medications, vaccines, and of course, we value your concerns and your opinions. We want to answer them for you, okay? I read an article yesterday which noted that a year ago, 3% of the infections were in children. This year, at the same time, 22% of the infection is in children. So we see that, it is increasing in the younger population. So it gives me another great hope with the horizon of the possibility of having the 12 to 15-year-old have a vaccine available. yet to be determined, hopefully in the next week or so. So hopefully we can get, the population, including the younger children, vaccinated. I want to thank everyone for their attention today and for, being here with us. And hopefully the program was informational for you. I cannot end without giving a shout out to my staff here at Lynn Boulevard Family Practice Center. I want to thank the nurses, my nurse Diane and Emily, the receptionist, and everyone here for all they do. And I want to thank all the listeners for their attention and for joining us today. You stay well and enjoy the rest of your afternoon.